Hi everyone, I'm Dr. Yang from Joint Shantou International Eye Center. Today's topic is bacterial orbital cellulitis. This disease could be life-threatening, so it's very important for you to make the correct diagnosis. So the learning objective is to make the correct diagnosis and institute prompt treatment for orbital cellulitis. First, I would like to thank Dr. Yuansheng Zhou for the pictures. Bacterial orbital cellulitis is a life-threatening infection of the soft tissues behind the orbital septum. It can occur at any age, but it's more common in children. The most common causative organisms are Streptococcus pneumoniae, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenzae. Let's start with the pathogenesis of bacterial orbital cellulitis, including sinus-related, most commonly ethmoidal, typically affects children and young adults. Extension of the preseptal cellulitis through the orbital septum. Local spread from adjacent dacryocystitis, midfacial or dental infection, and the last condition may cause orbital cellulitis via an intermediary maxillary sinusitis. Hematogenous spread. Post-traumatic, which may develop within 22 hours of an injury that penetrates the orbital septum. The typical clinical features may be masked by associated laceration or hematoma. Lastly, bacterial orbital cellulitis may complicate retinal, lacrimal, or orbital surgery. In bacterial orbital cellulitis, patients usually present with rapid onset of severe malaise, fever, pain, and visual impairment. On physical exam, we can find the following signs: unilateral tender, warm, and red periorbital and lid edema. Also, the bulbar conjunctiva is severely edematous and protruding. Proptosis, which is often obscured by lid swelling, and it's most frequently lateral and downwards. Painful ophthalmoplegia and optic nerve involvement. With the typical clinical manifestations, it's not difficult to make a diagnosis. Imaging examination helps to confirm the diagnosis. An actual orbital CT shows preseptal or orbital opacification, which indicates the protruding eyeball, the swollen orbital soft tissue, and the blurred orbital outline. A diffusion-weighted MRI shows high intensity in the cavernous sinus. Ultrasound examination shows enhanced anchor and thickened extraocular muscle. Blood test shows increased white blood cells, mainly neutrophils. Why orbital cellulitis could be life-threatening? Because some of its complications may be fatal. The complications of orbital cellulitis include ocular and intracranial problems and subperiosteal abscess. For local complications, we may find exposed corneal ulcers, raised IOP, occlusion of retinal artery or vein, endophthalmitis, and optic neuropathy. Because the bulbar conjunctiva is grossly edematous and protruding, the eye cannot be completely closed, and the bacterial infection eventually leads to corneal ulcers or even endophthalmitis. Due to the high orbital pressure and toxins, the optic nerve is involved. Vision is reduced or even lost. We could see dilated retinal veins, retinal edema, and exudation. Intracranial complications, which are rare but extremely serious, include meningitis, brain abscess, and cavernous sinus thrombosis. The last is an important complication which should be suspected when there is evidence of bacterial involvement, rapidly aggressive proptosis and congestion of the facial, conjunctival, and retinal veins. Additional features include a rapid progression of all clinical signs associated with protraction, severe headache, nausea, and vomiting. Subperiosteal abscess is most frequently located along the medial orbital wall. How do we treat bacterial orbital cellulitis? Orbital cellulitis requires immediate hospitalization with ENT assessment and frequent ophthalmic review. Given the potential severity of this condition and the spread with which it spreads, you'll start on broad-spectrum intravenous antibiotics immediately. These drugs are effective against a wide range of bacteria, including both Streptococcus and Staphylococcus bacteria. Antibiotic therapy should be continued until the patient has been apyrexia for 4 days. We should closely monitor optic function every 4 hours by testing pupillary reactions, visual acuity, color vision, and light brightness appreciation. During hospitalization, some tests should be performed and or considered depending on the disease course and treatment response. These include the following: white cell count, blood culture, CT of the orbit, sinuses, and brain. Orbital CT is particularly useful to exclude a subperiosteal abscess. We should do a lumbar puncture if meningeal or abnormal neurological signs develop. Surgical intervention in which the infected sinuses and orbital collections are drained should be considered in the following circumstances: lack of response to antibiotics, subperiosteal or intracranial abscess, atypical features which may merit a biopsy. Let's briefly summarize. Orbital cellulitis is an infection of the fat and muscle tissues within the eye socket or orbit. Although it can occur at any age, but it most commonly affects young children. Streptococcus species, Staphylococcus aureus are the most common types of bacteria that cause this condition. Symptoms include fever, protruding eye, pain, swelling and redness of eyelids, and visual impairment, etc. Without treatment, orbital cellulitis can lead to extremely serious complications, including meningitis and cavernous sinus thrombosis. Doctors usually treat orbital cellulitis with intravenous antibiotics, but some people may also require surgery. These are my references. Thank you for joining us. See you next time.